Okay, thank you, everybody. Everybody can see me and hear me okay? I'm not
Yeah,
in my usual location here.
yeah, we can see you and hear you.
Okay, good. Yeah, let me tell you about what's going on here because this is not what I planned. And I've always been told very early in my career, somebody told me, you never start a presentation by apologizing, which is probably good advice. But I kind of am. My plan for this month was to cover malaria, which is a bug that I've really kind of gotten interested in and really kind of enjoy working with these days. And there's some news about malaria going on. Um, but things have been so hectic in the lab that I never really got a chance to work on that. And I said, no, no, no big deal, because I knew I was going to be spending the 2 weeks right prior to this presentation, and I'm still up here in Northern Illinois, watching this kid while his mom and dad went on a trip over to Italy. And of course, I said, I've got 2 weeks with just this little kid here, my wife and this little kid, a little 3-year-old. No problem. I'll have plenty of time to work on this presentation. Yeah, right. That didn't happen nonstop. And then the times when I could have some time to sit down and work on something, I got this. Uh, Everything's going wrong. I was not able to connect on my computer. So I said, okay, I can't do malaria. Can't do malaria. So let's punt that. Let's kind of shoot for malaria for August. And let's kind of pick something that's a little bit more current, something that's meaningful right now. And what I was doing anyway, all my spare time was spent on this a blood culture bottle. So let's talk about blood culture bottles. Now, this might be something that some of you are sick and tired of hearing about after the last few weeks. But I'm going to talk about it anyway, okay? Because I was working on it and it was easy, and I was able to jump in there and actually recycle some of my slides from 2 years ago this month when we first covered blood cultures in these grand rounds. So let's talk about blood cultures. Obviously, a critical specimen. Those of us in the lab kind of look at it and say, there's really no other specimen that is as critical as blood. You can make an argument for spinal fluid, but the volume just isn't there on spinal fluids. Obviously, a positive blood culture can be anything from contamination all the way up to a very severe life-threatening infection. You need it to decide appropriate antimicrobial therapy. This is not like strep throat, where if you suspect strep throat, you know what to give. This is not like a typical urinary tract infection, where you know what's going to work 95% of the time without even doing any culture whatsoever. Um, Blood cultures are used with a wide variety of signs and symptoms. You will often feel the need to do a blood culture with all kinds of different types of symptoms, and it's common. Other than urines, this is the most common type of blood of culture that we do. Um, but things are going wrong. Things are going wrong. And as a little bit of a review, these are some slides that I stole from myself from 2 years ago. These are the three common types of bottles: the Bactec bottles, the Bacti-Alert bottles, and the Versatrek bottles. All of them have this fairly enriched medium. They have an anticoagulant. You put the blood in these bottles, you put them on the machines, and they will incubate on an instrument. Um, just to give you a little bit of perspective here, I'm making these numbers up. This is the wide perspective as far as how common these bottles are used. Really, just about half the laboratories in the world will use Bactec bottles. The other half will use Bacti-Alert bottles, which are made by bioMérieux. Uh, and there's a small percentage, let's say about 10% of labs out there utilize Versatrek bottles. Bactec bottles and Bacti-Alert bottles are plastic. Versatrek bottles are still made from glass. Um, so when we talk about a problem with one of these manufacturers, if we talk about a problem with the Bactec bottles, we're talking about almost half of the laboratories in the United States, certainly, possibly across the world, are having issues. And just to kind of revise, go back to some of this stuff we've talked about before. You have a blood culture bottle. The blood is drawn into the bottle on the floor. It comes to the laboratory. These are our Bactec instruments. It just slides into one of these slots here where it is incubated uh, for typically for 5 days max. This brown bottom may look like nothing to you, but that is really where all the action takes place. If a bug grows, it's going to produce carbon dioxide, which will diffuse through a membrane into this brown goo, which will actually start to fluoresce. So at the back of these little wells on this instrument, there is a UV light that will shine through every 10 minutes or so and look for fluorescence. And that's how it tells whether it's positive or not. Um, most bottles, if you look at this green light, I don't know if you can see that green light right there. That means there are negative bottles on that machine. They've been there for at least 5 days. They're done. There's no growth in those machines. We take those out, we throw them in the trash. Okay. And usually right about 90 to 95% of all blood cultures are going to be negative. You may get this little red light, which means there's a positive on there. And we're going to pull those positive bottles off and we're going to work them up and do gram stains, do rapid molecular, do culture from those. So that's what's supposed to happen. And it works great almost all the time. What's going wrong right now is with this bottle. Uh, it's made by Becton Dickinson, BD. They make the media. They don't actually make the plastic bottle. The manufacturer that makes the plastic bottle itself is having, let's say, production problems. And so in June, we get this letter that says, I like the way they say this. This is companies kind of understating the problem. You may experience intermittent delays in the supply of some blood culture media. Okay. Makes it sound like, perhaps you might. That was June 11th. It escalated considerably since that point. It is a very definite shortage, international shortage of getting these bottles. What we've been told is that what our usual order is, we're probably going to get about 50% of what we usually order. Up until last week, we figured we were actually getting somewhere around 20% of our usual order. So there was a significant reduction. That means we need to cut the utilization of blood cultures. So that's what's going wrong. This is not just another shortage for me. This one really is freaking me out. The reason it's not just another shortage, we can't replace anything here. We'll talk about using different bottles here coming up in a bit here, but there's not really any replacement. And for an example, go back to the beginning of COVID. If you remember the beginning of COVID, not only was there a shortage of COVID tests, but all of a sudden there was a shortage of swabs and there was a shortage of the viral transport medium. When we started running out of viral transport medium, it was not a huge deal. We were able to switch to saline. We made thousands of little tubes of saline in our own lab, and we're able to use that. We had to do some validation to make sure that saline was going to work, but it was okay, and it worked. So we could replace that. It did take a heck of a lot of manual labor to do that, but we were able to do it. We can't do it with the blood culture bottle. I cannot produce this bottle in my own laboratory. The distribution to the floors is a little bit different. Smaller facilities, small hospitals are probably going to have like a lab-based distribution where the lab will get these shipments that will come in of these bottles. They will send them as needed to the floors. But in a large facility, in a system, what's probably going to happen is that the bottles will go to a central receiving, a purchasing department, a central warehouse, and they will be distributed there directly to the floors. What that means is that in our facility, I do not see this bottle at all until it shows up in the micro lab with blood in it. We don't really have a way to police the sending out of these bottles. So the distribution makes it a little harder to keep track of. And when you get down to it, it's not just a lab product. It is a specimen collection product. You collect the specimen directly in these bottles. And as a result of that, the lab doesn't have much control of it. I'll give you an example. If this were a PCR reagent, let's say that the company that manufactures the herpes PCR kit that we use suddenly said, well, we're having a manufacturing problem and you're only going to receive 50% of your normal supply of this herpes PCR. Well, then the lab can have total control. We can collect these specimens in and we can prioritize them as far as which ones need to be done. I can't do that with blood culture bottles because by the time we get it, it's already been used. So this is going to be a considerably more difficult shortage for us to deal with. So I'm going to talk about the shortage a little bit and what some hospitals around the country are doing. Some strategies for dealing with this. Um, I threw this website in here. This is actually the notification that came out a few weeks ago from the FDA. It's got some recommendations on what you can do. Most of what I'm going to say is kind of a reiteration of what's in this or what other hospitals have kind of come up with. But certainly there's a place to go if you want to kind of know some more about what's going on and what you can do with it. So taking some data that's come from our facility and also from some other hospitals around the country, what are some strategies for dealing with this blood culture bottle shortage? Here's one that I thought of right off the bat. Stop the rainbow draws. Now you might be thinking, wait. I know what a rainbow draw is. I know, a patient comes in typically to the emergency department and they're just going to immediately draw several different color tubes uh, just in case they are needed. Yeah, okay, I'm not going to argue about that. There are some publications that have come out recently that say that it's really not worth doing. It's not a good thing to do. But blood culture bottles are not always in that rainbow draw. I have talked to several emergency department nurses who've said certain criteria. They will look at a patient and think, okay, this patient might need a blood culture. So at the same time, they'll go ahead and draw blood culture bottles as part of that rainbow draw. So they don't need to go back and collect them again later. I don't think it's a huge thing, but I will give you some data from 2014. What we saw at the time was of all the blood culture bottles that we purchased, 1/3 of them never made it to the lab. 1/3 of them were never came to us and actually used for a blood culture. I figured that out when we were uh, coming up with a contract for our new blood culture machines. And the company was saying, this is how many blood culture bottles we expect you to buy every year. And I'm thinking, well, we can't buy that many. That's a lot more than the number of blood cultures we actually do. And they said, well, it might be more than you do, but it's nowhere close to what you actually buy. So we were throwing away hundreds of thousands of dollars of blood culture bottles every year. Uh, Now, that may be because some of them expired and they were thrown out. But most of those were ones that were drawn first before there was a blood culture order. And then the blood culture was never ordered. So that is a strategy. That is a process that if it's being used for blood cultures, it has to stop. Let me step back a little bit. Like I said, about half laboratories around the country use Becton Dickinson, these Bactec bottles. If you're using BMR or U bottles, you're fine right now. Right now, you're okay. They had their own problem about 5 or 6 years ago where there was a blood culture bottle shortage. If you're using Versatrek bottles, you're fine right now. I have heard through the grapevine that Versatrek, even though they're using glass bottles, has sent out a notification that there may be some shortages coming up. So, we'll see. Anyway, these rainbow draws, if you are drawing blood cultures before there is an actual blood culture order, that's got to stop. Otherwise, we got to reduce the use. We have to reduce the use of blood cultures. And one way to do it is just plain old, good old diagnostic stewardship. So here's some slides that I showed you 2 years ago. Who should get a blood culture? Current practice guidelines do not indicate specific indications for obtaining blood cultures. Okay, that's from the CLSI document that came out in 2022. Healthcare practitioners probably overestimate the likelihood of bloodstream infections. Okay, I kind of look at it and say, what's the percentage? How certain do you have to be that this patient has a bloodstream infection before you pull the trigger and do a blood culture? I kind of look at it personally and say this could be a very serious infection. We don't want to miss a blood culture infection because we didn't even look for it. But the CLSI also points out incidence of true bacteremia is only slightly greater than false positive results in certain populations. So if you look at the data overall, the idea is that we do order too many blood cultures. We order more than we really need to do. So CLSI recommends these situations for doing blood cultures on the left. If it's not one of these, then a blood culture is not really indicated. So certainly we can pull back. We can reduce our utilization of blood cultures to some extent by sticking with these indications right here. So as far as specific responses to this shortage, let's look at what a couple other hospitals have done. This is from Virginia Commonwealth University. They created this and sent this out to their physicians a few weeks ago. It was in middle to late June that they sent this out. Basically listing over here, low risk conditions. If you have these situations, there is no reason to really be doing a blood culture. Okay. Isolated fever, even if they have leukocytosis, fever with a high white count is not an indication to do a blood culture. Low risk situations there. So they're telling their physicians, please, when you have these situations, don't run a blood culture. These are situations where you definitely do need to do a blood culture. There's a high risk. That's when we want to get a blood culture. And they also point out, as far as doing repeat blood cultures, document clearance for Staph aureus, Staph lugdunensis every other day, catheter-related bacteremia prior to replacing the catheter. And don't repeat until you've done at least 24 hours of antimicrobial therapy. We've seen situations where physicians, for better or worse, rightly or wrongly, will order a standing order, daily blood cultures for 10 days. That's something that we can't have. We can't do that. But if you look at this is what Virginia Commonwealth specifically came up with to deal with this shortage. But if you look at it, this is just plain good diagnostic stewardship. There's nothing special in here as it relates to the shortage itself. So let's take a step up. Vanderbilt got a little heftier with this. July 2nd, first of all, hard stop for blood cultures ordered within 48 hours of prior culture. You get one blood culture, and you're not going to get another one for at least 48 hours. The computer system will stop it. So there is a pretty hard restriction there. A single set. And this is one thing that kind of bothers me, and we'll talk about this more in just a second. We've always harped, especially on the adult side. Please, 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 you want to always send 2 sets.
Drug interactions. If it's a kid in the ICU, anytime they're
Okay,
on a circuit,
I'll try to talk over this.
go get
You always want to do 2 sets.
the totals.
Okay. And they're saying, no, you're only going to do 1 set. So here are the recommendations that they say. No blood cultures in these situations right here.
But on the off chance, always.
So that's a little tougher. They also came up with this algorithm. I'm not going to go through the whole thing, but notice it's a nice long algorithm for figuring out whether you need a blood culture or not.
Because of the protein binding differences. But we really shouldn't be seeing a lot of BPA, obviously, in those smaller.
Sorry, Dr. Junkins. I just muted everyone. If you can unmute yourself, only Dr. Junkins. Perfect.
I think I'm good. Am I good?
You're good now. Sorry, I had to mute everyone, and now we're good. You can keep going.
Okay.
Thanks.
Not going to go through this whole thing here, but for adult non-neutropenic patients, and you can certainly read down through this and see what they're suggesting. So we have to reduce use of blood culture bottles by only running them in situations where there's a fairly high risk. Okay. Here's the other strategy. Reduce the number of sets, just like we talked about Vanderbilt doing. Here's again some slides that I showed you 2 years ago. This is what's recommended. We always want 2 to 3 sets. 1 aerobic, 1 anaerobic bottle. Okay, that's a set. then come up with another aerobic and anaerobic bottle. That's 2 sets. We always want those. The reason is we want adequate volume. For those backtick bottles, we say 8 to 10 mils per bottle. If you only do 1 set, you're only getting a max of 20 mils, which, believe it or not, is not really enough for really, really good sensitivity. You want the best possible sensitivity. We need adequate volume. And also to assist with contamination. If you got coordinator staph in 1 set, but it's not in the other set, then I'm thinking, okay, that's probably a contaminant. It's much, much harder if you've only got 1 set and it's got coordinator staph. Then we don't really know what to do with that. So the recommendation is, and always has been, we want 2 to 3 sets per episode. But this is what we're starting to do now. Reduce to 1 set every 48 to 72 hours. Okay. Say, no, step that back. Instead of doing 2 sets, send us only a single set. Even like Vanderbilt did, restrict it to say, we're not going to do, we're not going to let you do 2 sets. Obviously, if you think about it, if you go from 2 sets or 3 sets down to 1, then you can reduce uses by 50% or more right there. Which, if you think about it, what we're being told is we're going to have a 50% reduction in our supply. This alone could be enough to handle the shortage. Okay. But look at all the bad parts. You're going to have less volume, so you're going to have less sensitivity. Okay. So you really want to stress, if you go back to 1 set, you really want to stress to your phlebotomist or your nurses, whoever's collecting these blood cultures, we want the full 8 to 10 mils per bottle. Don't waste a bottle by sending us a bottle with 2 mils of blood in it. 8 to 10 mils to get as much volume as we can in that bottle. Like I said, complicates the determination of contamination. So go back to your phlebotomist, go back to your nurses and say, you really got to keep in mind your blood culture collection procedure. Excellent antisepsis to make sure we don't get contamination. You do run into problem with compliance with CMS sepsis guidelines. I don't know enough about that to really comment on it further, but it can be handled. There are ways. I'm sure somebody on this call can speak to that much better than I can. And then the question is, what harm is this going to cause? I mean, like I said at the beginning, this is a critical specimen, and we've always harped on how important this type of specimen is and how important blood cultures are. If that's true, then by cutting back, we're going to be causing some risk. We have to kind of see what kind of risk that's going to be. Is requesting change enough? You can request this. You can provide education. You can provide some guidelines, some algorithms, and say, doctors, physicians, please do this. Please do not order blood cultures unless they're absolutely needed. But physicians are still free to do what they feel they need to do, okay? How big of a reduction can be expected? One place put out that good antimicrobial stewardship and say, please, these are the situations where you do not need a blood culture, and they got a 30% reduction in use. 30% reduction is really pretty good. Another place, which shall remain nameless, did the same thing and got a 2% reduction, which is not going to get us there. So then there's restricting to say, we're going to make it so that you cannot order blood cultures. So use physician order entry and whatever EMR you've got to basically say, you are not going to be able to order a blood culture unless the criteria for testing are met. There's got to be a workaround. There's got to be a way that a physician can kind of request that the criteria be lessened for this particular patient. But basically, you're going to say, for example, if you're going to restrict it, you're going to say only 1 blood culture every 48 hours. Then the computer is going to make it where you cannot order a second blood culture within 48 hours. Or the other possibility is the lab houses all the bottles. All the bottles that are out there on the floor, they're all in the lab. And so you can order a blood culture, but you're not going to get bottles for it unless the criteria are met. So here's what's going on here. Adult sheet here. Here are the criteria for a blood culture. And notice it is 1 blood culture. That's it. So the physician and the nurse are going to have to check to see that the patient does meet these criteria. These are criteria that do not count for a blood culture. And notice a blood culture is collected in the last 3 days. So what happens in this situation is that if you want to order a blood culture, you can order a blood culture, but you have to have this sheet filled out. The lab gets that sheet and the lab provides the bottles. We started this last week, and it's kind of hard to collect data in a very short amount of time. But what we're seeing is about a 60 to 64% reduction in the number of blood cultures done. Why not just use another type of bottle? We've had that. Why don't we just switch? Uh, well, first of all, these bottles go in these machines. Here's a Bactec machine for the Bactec bottles. This is the BacT-Alert Virtuo, which collects these bottles, and the Thermo Fisher Versatrek instrument. The bottles don't fit. I cannot go and start buying bioMérieux bottles and put them in a Bactec machine. Okay, it's not going to work. It's not going to fit. These bottles are considerably bigger. They're definitely not going to fit in either one of these two machines. So we can't just switch bottles. Plus, you kind of look at it and say, they measure differently. This is a fluorescent label. This is a colorimetric label. And this is based on changes in gas pressure. So even if I could put a bioMérieux bottle in a Bactec machine, it would never be able to read it. So can't be done. They are incompatible. So why not just use another type of bottle? Like I said, bottle A is not compatible with instrument B. Since I have Bactec instruments, I cannot go and use bioMérieux BacT-Alert bottles. Excuse me. Company A is not going to sell you a whole bunch of bottles if you don't own their instrument. Okay. bioMérieux has already said we do not have the capability to supply the entire world with blood culture bottles. If you don't have one of our machines, you're not going to get our bottles. We have to take care of our own customers who have our instrument. Now, one thing that you could do, let's just assume that you could get bottles from another company. What you could do is incubate them manually. This is the old-fashioned way of doing blood cultures. I just put the bottle in a regular incubator. I take a look at it every day and look for visual signs of growth. Is there turbidity? Are there little colonies growing on the cells that are agglutinated out in the bottom of the tube? And do a blind subculture. After 48 hours of incubation, after 5 days of incubation, I streak the bottle out onto plates. That is not going to happen. Even if we could get bottles from another company, it's just not going to happen. Extremely, extremely time consuming. We would have to hire 5 new people to start work tomorrow if we were going to do this. Very labor intensive, plus slower time to detection. Here's my personal opinion on it. For most facilities that are using BD bottles, the only way to get through this without running out of supply entirely is to put in some algorithms that will prevent physicians from ordering blood cultures or prevent nurses or phlebotomists from collecting blood cultures unless the certain restrictive criteria are met. Now, the facility is going to have to decide on what those criteria are. And it's going to be different from one hospital to another. It's going to be difficult from one patient group to another. We have a set of criteria for adults. We have a set of criteria for pediatrics. And it's going to change a little bit. You know, I'm kind of looking at this and say, what if things get worse? We're going to have to make those criteria more restrictive. If things lighten up a little bit, if things start looking a little bit better, then we can keep those criteria in there, but maybe weaken them a little bit. Maybe add in a few more indications for blood cultures. Let me point out, I didn't really say this. What we're being told is that the facility should be back up to full production sometime in September, not December, September. I kind of look at that and think it's probably still going to take us a month or two to kind of get back to normal supplies after that. So I'm kind of expecting that this shortage is going to be worst in the month of August. And kind of pick up a little bit. We'll kind of work our way back to normal, but may not get back to normal until sometime around the beginning of November or so. Theoretically, could even last into next year. So that's what I think we all need to be doing. What happens if and when we do completely run out of blood culture bottles? I'm not going to answer that. I thought about putting some text on this slide and just decided I didn't want to go there. Is it going to cause harm to patients? Yes, of course, it'll cause a harm to patients, a great deal of harm to patients. Um, exactly how bad it is, we just don't know until it happens. I kind of look at it as well from an antimicrobial stewardship perspective. I think this sounds like an antimicrobial stewardship nightmare to me. If you basically are going to have to keep patients, a certain number of patients on broad spectrum therapy for both gram positives and gram negatives, because you don't know what the issue is. I worry a little bit too with us switching back to only one set. We're reducing the sensitivity a little bit. Okay. So when we do one set and it comes back negative, is that going to be enough to convince a physician that there truly is no bacteremia going on here? Um, I don't know. I don't know. We may have a situation with just one set where we have antimicrobial stewardship problems as well. So I really didn't want to go anywhere and say specifically what we think is going to happen with this. I will leave that up to you to kind of figure that out. Um, and of course, anybody else who wants to add their 2 cents worth, then feel free. Obviously, it affects stewardship, it affects infection control. It infects a lot of areas of the hospital, not infects, affects a lot of areas of the hospital. So that is all I've got on this. I know some of you have been working real hard on solving this problem in your facility. Some of you are sitting back glad that you're not using this particular brand of blood culture bottle. Um, it's something, though, that many of us are going to be dealing with for another couple months or so. So next month, I'll do malaria. It may not be as topical to today's discussion, but it won't be such a downer. Feel free. Any questions? Any suggestions? Any additions people want to say? Feel free. I am all ears.
Thank you so much, Dr. Junkins. I'm so glad that you chose this topic because it is very important and very timely considering the shortage and all that we've heard. The CDC warnings about it, what should we do, recommendations from the CDC and the FDA, and then, of course, from the state. Does anyone have any questions for Dr. Junkins? All right. Well, we will let everyone go. Thank you, Dr. Junkins, for another great presentation.
Okay, thank you.
Thank you.